Welcome to another episode of Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
On today's episode, we're going to be talking about ACL tears, or the anterior cruciate ligament.
Yes. Common sports type injury. You've probably heard of one or two of your favorite athletes getting this injury.
Yeah, it's pretty common, and it's also common in non-athletes.
True.
Or non-professional athletes. What is the ACL?
Right. So the ACL stands for anterior cruciate ligament, and it's a ligament that exists in your knee. You can see a representation of it here.
Anterior, it's in the front.
It sort of runs from the outside to the inside, and it is the main structure that's responsible for stopping your knee from doing this.
So it's a ligament that connects one bone, your femur, to your tibia.
And it stops it, hopefully stops your tibia from pulling forward from under your femur.
And it's called cruciate because it crosses with your PCL, or the one in the back.
Right. And just for reference sake, you have other ligaments around the knee. MCL, which you've heard of MCL sprain before. LCL, so medial ligament, lateral. And there's a PCL, a posterior cruciate ligament.
And yeah, so the anterior and posterior cruciate ligaments are within the knee joint itself. So who usually gets this, Paul?
So this, I think, a typical ACL injury would be, say, a soccer player who jumped up to head a ball or something, came down on his leg and twisted it at the same time, or a skier who got a sharp twisting motion to the knee.
Yeah, or a knee on knee in hockey.
Knee on knee in
or
hockey. Basketball. So yeah, most usually it's during some sporting event.
I would say more commonly for me, I see them in the 15 to 50 range, like very rarely really young,
yeah,
and very rarely old. For
yeah, it can. You can have it in,
sure,
13-year-olds and that, but more commonly in that age group.
I find that when people tell me these stories, they say that they often hear or feel a pop in their knee, or someone else might have even heard it.
Right. So it's yeah, the injury occurs, sudden pain, heard a pop. Sometimes, often, but not all the time.
Yep.
A lot of swelling, and
yep,
then inability to finish the game or finish the run if you're skiing, and difficulty weight bearing.
Yeah.
Right after. Those are the classic sort of story. And then we think, oh, that might be an ACL.
And maybe even some acute instability where they say, my knee felt like it was trying to give away. I was able to walk on it, but then my knee was giving out, so I had to stop.
Right. Okay. So you've had this injury. You think it might be an ACL injury. What do you do?
So you need to seek some medical attention. So that's either your family doctor, walk-in clinic, emergency room, I guess, depending on the severity. But it should be, sooner rather than later.
I think so.
And when you go there, your family doctor's going to take a history. They're going to do a physical examination, and like Paul talked about, they're going to find swelling. They're going to find reduced range of motion. They're going to find some pain, and then they can do some specific tests that test the anterior cruciate ligament.
Right. And on that physical examination, sometimes the physical examination is hard to do acutely if you're looking for an ACL injury, because the knee is swollen, it's inflamed, and some of the special tests we do are difficult to do in that acute phase. So often what I'll say is, okay, look, I'm worried about your ACL. I'm doing my physical exam. I'm going to get you to go home, do some physio, settle the knee down, and come back and see me in 2 or 3 weeks and let me re-examine it.
Yeah, I'll do the same thing, and then depending on my index of suspicion, I may already start ordering a bunch of tests.
Right.
But yeah, bring them back. Hopefully the swelling's down,
yeah,
pain's down, and then you can actually test it and do one of two different tests, primarily that I do, or called the Lockman test and the anterior drawer test, which are specific tests for the knee where we're trying to see how much the tibia comes out from underneath the femur.
Right, we're just testing its stability. And of course, history, physical examination are always, in our line of work, followed by an X-ray. So you want to X-ray the knee to make sure there's no other injury going on, there's no fracture associated with this, or maybe this isn't an ACL injury, maybe this is a fracture.
So is it going to look dislocated on the X-ray, Paul?
No, you know what? In an ACL injury, it's usually everything looks pretty normal. The bones look pretty normal. Sometimes you can see signs of an effusion, so you can tell that there was fluid in there, but that's really what you're going to see clinically. An effusion is just a joint that's filled with fluid, probably blood in the case of an ACL tear.
What about ultrasound? Seems to be a test some people like to order.
Ultrasound of the knee is almost completely useless. I think we might have touched on this on a video before, but ultrasound of the knee, really, if you're worried about a tumor or something like that, then you'd order an ultrasound of the knee. But otherwise, I don't get any extra information from an ultrasound of the knee.
No,
certainly not for an ACL.
Yeah, more commonly used for like a blood clot in the leg. So,
yeah.
What's your number one test? What's your go-to test?
The diagnosis of an ACL injury is made clinically with the history and the physical examination and supported by an MRI.
Yes, exactly. And then so the MRI will tell you whether it's a partial tear, whether it's a complete tear, and whether there are any associated injuries like a tear of the meniscus, which is not uncommon, a strain of your medial collateral ligament, which is not uncommon, some bone bruising, often because the leg ends up in a very abnormal position and is loaded acutely in an abnormal way that will cause edema or bruising on the MRI. Okay, so now you thought it was a torn ACL. You got your MRI confirmed as an ACL. You're seeing them say at 3 weeks now or 4 weeks or however long it took you to get your test. Now what?
Well, now we really recognize the problem with the ACL. A medial collateral ligament tear, sprain, will usually heal on its own. About 6 weeks of bracing and some physiotherapy, and your collateral ligaments will heal. The ACL, however, very, very, very rarely can it heal on its own. Usually an ACL rupture is permanent unless it's treated.
Yes. And okay, so you say, okay, fine, it's probably not going to heal just on its own.
Yeah.
What if I said, I don't want to fix my ACL. I just want to.
Okay.
Can I live with it?
You can. I mean, you can live without your ACL. A lot of people do. A lot of people have ACL deficient knees from previous injuries that maybe were never even diagnosed. The problem is that if you're an active person and you're doing any sort of sports, even leisure activities, you might feel instability with your knee. You probably won't feel any pain with a ACL rupture once you're past the acute phase, but you may have instability where if you try any pivoting activities, you feel like your knee subluxes, we say, where the tibia moves unnaturally under the femur.
Yeah, it's going to give way. I tell people they can run straight ahead as fast as they want, but often if they try to turn,
don't stop.
Just don't. So you just got to run, of course.
But yeah, so that's probably the main reason that we recommend having your ACL reconstructed.
Okay, so before we get to reconstruction, so when I see someone, I tell them, hey, let's get your knee strong. Mm-hmm. Let's get you into physiotherapy to get your knee strong, to get your range of motion back, to get your swelling down, also get you fit for a brace in the short term. Mm-hmm. And then once you get to the point where you're considering a surgery, then what happens? Like, why do you do it? Why do you want surgery?
Okay, so the ACL is not the only structure that stops this abnormal motion. There's other structures, and that's part of the reason we do physiotherapy, to try and strengthen the other structures around the knee to see if it can compensate for this ACL deficiency. But if we've examined your ACL, and then you come back again 3 weeks later, and we examine it again, and you're still just as stable, or you're getting more unstable, progressive instability, then we say, yeah, you should have this reconstructed. And we use the word reconstructed because we can't repair it. You can't just go in and put a stitch across the ACL and have it heal. It won't heal. You need to replace what the ACL was with another structure. So it's called a reconstruction.
Okay. And that obviously, there's a variable number of operations that you can do from the type of graft that you use, the location that you get it from, and how the procedure is done. There's certainly lots of different procedures that you would discuss with your treating surgeon.
Right. And is the recovery quick for this one?
So I would say yes and no. Okay. I mean, you're not in the hospital for 3 weeks with it, but yes, no, this is a long, drawn-out process, often 6 to 12 months to full recovery, with the hopes being that you can return to sporting activities, potentially even professional sports. Lots of athletes have come back from ACL tears.
All right. Okay, so now let's say I've had my ACL torn. I'm considering reconstruction, or considering not having surgery. In terms of later problems in my knee, what do you tell your patients about that? So
I tell anyone with any type of injury that once you've had that, your knee is never going to be normal, because some component of the injury could be irreversible. When your knee moves like that, the cartilage is loaded in an abnormal way for potentially very short periods of time, but potentially could cause long-term damage, and particularly arthritis. That's probably one of the number ones. The other one is that even after you have your ACL reconstructed, you may still have some subtle instability or some subtle pain or some subtle loss of range of motion.
Or you could re-rupture it again.
Absolutely.
Sure. So if you think about your ACL ruptured in your knee now that's not controlled in the same way, let's say you recover, you don't even know you tore your ACL, but the next time you go out to do your sports, you sublux your knee, you could do more damage to your knee. Now that it's moving in an unnatural way, you could damage one of the menisci, or you could damage the cartilage, or you could have more damage. And then the other problem is that in your ACL deficient knee that's not working like it normally did before you popped it, you're at risk for developing arthritis, like Dr. Wing said, in that knee. So then the question is, well, okay, what if I reconstruct my ACL? Am I obviating that risk of arthritis down the road?
I would have to say no. So unless you got in a time machine and went back in time and then didn't rupture your ACL, I think that part of that injury is irreversible. So no. Yeah. You may reduce the rate of progression, but I think you cannot remove that risk.
Right. So, the evidence isn't very cut and dry on this, our scientific evidence saying whether or not or how much you're reducing your risk of arthritis, but it makes sense that if we try and bring the knee back to functioning as normal as possible with an ACL reconstruction, that maybe we can decrease the chances of developing arthritis down the road or the severity of the arthritis that you might develop down the road. But there's certainly no evidence that proves that for us. Certainly, like Dr. Wing says, once you've damaged that knee, you're at risk for arthritis down the road.
So yeah, kind of like we're talking, no one has to have an ACL reconstruction. It's not a tumor, it's not cancer, it's not infection. But we think everyone should probably have the discussion with a specialist to find out the pros and cons and what's going to be right for your level of activity.
All right. Anything else on ACLs?
Just try not to get one.
Try not to get one. Good point. Actually, that's a good point. Bracing it prophylactically. People have looked at that, putting braces on to reduce the chance of an ACL injury in football players, for example. But again, that hasn't been adopted as a routine thing.
No, one thing that has, though, is very specific kind of prehab physiotherapy treatment plans for particularly women in soccer, because they have been shown to have unique risks. So strengthening the muscles around your knee, I think, in general, can reduce some of that risk. But yeah, in general, I don't think prophylactic bracing is probably not the answer at this point.
Right. Thanks again for tuning in.
If you have any further questions or topics you'd like to discuss, please email us at talkingwithdocs@gmail.com.
And remember, you are in charge of your own health.
See you next time.